Our first nephrotic syndrome we'll take a look at is the most common type in children. Welcome to minimal change disease. Why do we call this minimal? Because, well, there are three patterns of imaging or staining with biopsy. Those included light microscopy, electron microscopy, and immunofluorescence. Now, can you predict as to what you're going to find in a little bit of each one? Let's do it. Ready. Light microscopy looks perfectly normal, hence minimal. So when you say minimal change of disease, it's the fact that you find minimal changes in light microscopy. Not enough to confirm biopsy, or not enough to confirm diagnosis. Your next pattern biopsy here with electron microscopy, well, a lot more diagnostic, because you find diffusion of foot processes. And then what about immunofluorescence? What can you predict? Well, the immunofluorescence here would not show any immunoglobulins because that is not the type of pathogenesis that we're seeing. Now, that's your child, most common. And do not forget that adults may get this as well. It's more common in girls than boys. Now, occurs in 15% of adults with nephrotic syndrome. 15%. What kind of association? It's usually cancer. Usually dealing with Hodgkin lymphoma. Keep that in mind. T cells is where we are here with cytokines. Remember, if it was nephritis and inflammation, then you're bringing in neutrophils as being your primary pathogenesis. If it's nephrotic syndrome, it has to be cytokines mediated by T cell. Here, with T cell cytokines, you'll have damage to the glomerular basement membrane. Gone is a negative charge, therefore facilitating the release of your albumin. Albumin. It's selective proteinuria, not globulins. Remember, when we did our discussion of urine analysis, we did salicylic acid, SSA, and that was more specific for looking for globulins, salicylic acid. Here with albumin, it's the fact that you're looking for this through your albumin dipstick. Well, you would already know there's loss of protein because there'll be generalized edema in your patient. Secondary cause, Hodgkin's lymphoma. What must you find upon histology with Hodgkin? A Reed-Sternberg cell. What's the most common? Nodular sclerosing. Remember, 15% of your adults may present with minimal change disease. It is the most common in a child. So the mother brings in the child, or maybe you're taking your clinical exam and you walk into a room and instead of a patient, there's a telephone. What? Don't panic. You know enough in which you can communicate properly and effectively with the mother on the phone. And are these real-life exam questions and exam scenarios? Of course they are. So you get on the phone and the mother tells you that, the child is gaining quite a bit of weight. The child is urinating quite a bit. And now at this point, with that type of history, you're already thinking and suspecting that this child probably has minimal change disease. What's your next step of management? Not biopsy. Clear? Not biopsy. So what is your next step of management? Corticosteroids. Is the child going to recover? Yeah, absolutely. Does that make you feel good? Whew, yeah. Structural abnormality with minimal change disease. Stains. You're looking for fat stains. Negative immunofluorescence. We already discussed this. Why? It has nothing to do with immunoglobulins. It's selective for albuminuria. Next, often preceded by respiratory infection or routine immunization. Usually normotensive, so hypertension is usually not present. The nephrotic syndrome include, we talked about hypoalbuminemia. There's going to be generalized edema, and the fact that there is going to be lipoid. Children will respond quite well to steroid therapy. Try not to do a biopsy in a child. You don't have as many differentials with these type of symptoms, and so therefore steroid is your next step of management. Is that clear? Now, if it's an adult, that's different. With an adult, we have a lot more differentials, and so therefore your next step of management would be biopsy. Chronic renal failure, thank goodness, is where minimal change disease on electron microscopy. What are you going to find? Well, what you find on these pictures of electron microscopy is the fact that, let's do the same thing over and over again. So you get in the habit of looking at this organization pattern. First thing, basement membrane, smooth, paved road, number one. Number 2, what are you looking for? You're looking for feet. That puts you on the side of your podocyte and epithelial cell. But the problem is this. Oh my goodness, where are my feet? I can't find any feet, Dr. Raj. You're right, because they're all fused. The fusion of the foot process is my problem when dealing with nephrotic syndrome, and the picture is here with MCD that you have fusion of foot processes. Clinical features, responsive to corticosteroids, and the majority will in fact have complete recovery. Fusion foot processes, what you're seeing, and on a cartoon, if you take a look at where it says epithelium with the phased foot processes, not a single foot process is seen on top of that base membrane. You see that gray visceroepithelial cell. A beautiful picture there of where you find no foot processes. Would you find any immunocomplexes here? No, you would not. It has nothing to do with immunoglobulin. Findings occur in all glomerular disease that present with nephrotic syndrome.